Well, I guess we can start slowly. If Eugene's okay to start soon.
Absolutely, yeah.
All right, so welcome everybody. There's probably other people that will join in, so bear with us for the beginning. It may be a bit bumpy, and I put everybody on mute so we can all listen and hear Dr. Bereza speak nice and clearly. If you have a bad connection, Wi-Fi connection, I do recommend that you put your video also on stop, so it will help with your Wi-Fi connection. So we have the pleasure of having Dr. Bereza today presenting on medical directives, promises, and pitfalls. Just to introduce to Dr. Bereza to the group, he's a well-known bioethics with a background in literature, medicine, and also in palliative care. He has a quite extended CV, but I'll just give you some highlights. He's a former director of the Biomedical Ethics Unit at the Faculty of Medicine, as well as the founding director of the Center of Applied Ethics at the McGill University Health Center. So he's going to bring with tonight over 30 years of experience and over 2,500 clinical case at the bedside. So a lot of practical knowledge. He's also he was awarded Kenyan Medical Association Dr. William Marsden Award in Medical Ethics in 2010. In 2015, he was the elected president of the Kenyan Biotech Society. And in 2019, he was also awarded the Society Lifetime Achievement Award. Quite a CV. So Dr. Bereza agreed to present about advanced directives, and he will allow some questions at the end of the session. So for people that are not familiar with the Zoom presentation, you could chat your questions and I'll collect them, and at the end of the presentation I'll do a summary of your question, comments, and we'll allow Dr. Bereza a good chunk of the time, and also some time to exchange and interact, because that's the part of the McGill Council on Palliative Care. It's really to raise awareness, but also to help you guys in the community to access better palliative care. So without any delay, I'll let Dr. Bereza present, and welcome, Dr. Bereza, and thank you for allowing us to capture your wisdom and your knowledge.
Merci, Patrick. Thank you very much for that introduction, and good evening, everybody. First of all, thank you very much for the invitation to participate in this webinar and to present you some views and hopefully what might help. So let's move right along. I'm just going to give you my first slide is what am I trying to accomplish in the time I have? What are my objectives? What's the main issue? What's the promise? What are the good things that can come out of this? What are the pitfalls? What are the things that don't work that you need to be aware of so you don't get caught in these bad things? And I'm going to actually at the end make a recommendation. What's the best way to move forward for people so that you don't fall into some of these problems? And then if we have time, I'd love to answer whatever questions I might be able to. So here are 3 objectives I have for this session. The first is I want you to become aware, if you don't already know, what are the different kinds of advanced directives you can have? Because there's not just one kind, there's many different kinds, and they all have pros and cons, and you want to be aware of what those are to use those to the maximum for your own benefit. So the second thing is to really be aware of the advantages and the risks of each option. And finally, I'm going to try to offer you, based on my experience, as Patrick mentioned, I've been doing this for about 30 years and well over 3,000 cases, and many of those cases involved advanced directives and people not always being sure what their rights are and what they could do with that. I'll give you my personal opinion, what strategies are most effective and which ones maybe less so, okay? So there's good news and there's bad news. I always start off with the bad news. Well, the bad news is, we've obviously, I personally think we've improved a lot in the last 30 years about how to strengthen patients' rights. This is all about making sure patients' preferences and wishes are respected as much as possible, especially towards the end of life and what they would want done. But we can always do better. We still know the system is not perfect. There's many areas where we can and should improve. At the same time, I got to say, though, you know, we have to have, and I'm speaking as a patient. I'm also a patient. I'm not just a physician. I've been a patient at the MUHC for many years. You know, we have to have realistic expectations. And sometimes people, I find, are so anxious of making sure that their wishes are met immediately, exactly, perfectly, that they want some sort of guarantee, some sort of foolproof mechanism. Well, you know, there are no guarantees in life, and this is probably no exception. We can make it as close to perfect, but we can't promise perfect. Life is too complicated for that. And honestly, my personal opinion is forms are not going to be what give you the guarantee. It's talking to the right people that's going to give you the closest to the guarantee. But I'll get to that. On the good side, the good news is patients in Quebec, especially, I think, have very strong, very well established ethical and legal rights. On that score, you need to be reassured that you have very powerful rights to have your wishes at the end of life respected. That's enshrined in law, it's enshrined in medical ethics, and it's very powerful. So if you're worried, you say, oh, how do I fight for my rights? Those are already very well enshrined in our laws. The other good news is, I think, honestly, the medical profession has come a long way from when I was a medical student. I think it's fair to say, you know, that 35, 40 years ago, things weren't so great. There was quite a bit of medical paternalism. We often thought we knew best for everybody and made the decisions for our patients. We probably didn't listen as much as we should have. But I think there's been a lot of transformation within the medical community, especially within the young generation. And I think things are not anywhere near like that anymore. Things have really changed dramatically for the better. Not perfect, but much better. I'll give you some examples of where your rights are so strongly enshrined. So just a couple examples. I'll go slowly because some of this is maybe new to you, but maybe not. In the Civil Code of Quebec, it states right up front, every person is inviolable and is entitled to integrity of his person. That's the bottom line. So except in cases provided for a law, when there's exceptions, no one may be interfering with you without your free and enlightened consent. So already, right there, you know, doctors, nurses, we can't do anything to you as a patient without your consent. So the kind of concerns I'm assuming many of us have, and I talk to patients all the time, is their primary concern is, oh my gosh, when I get to a certain point, if I get to the point where I'm very ill, and if I don't want crazy things, heroic things done, how to make sure that that's respected? Well, what you need to understand at the outset is your rights legally are very clear. I'm not, as a physician, I can't even touch you, do anything to you without your consent. So if you don't consent to having those things done, we can't do it. Bottom line. Now, obviously, it's a bit more complicated than that. What happens when you can't speak for yourself? You don't lose your rights. Somebody represents you, your family, somebody with a mandate. We'll get to that. But your rights are always there. They're very powerful, and you always have them. Another example of how your rights are really well enshrined in law, you know, in Bill 2, which codified end-of-life care in Quebec, that was based on respect and the dignity of the autonomy of the dying patient. It was to organize and frame end-of-life care in that context. And the primacy, the prime directive there was recognition of patient's desires, patient's wants, not the medical doctor's wants. It's what the patient wants that's the prime area of concern. Okay? So those are just two examples of how powerfully patients' rights are enshrined currently already in our existing framework. So if it's that strong, what's the issue? Where's the problem? Well, instead of just continuing with an academic presentation, let me frame it by giving you a few cases, just to give you a sense of the scope of the kind of issues that come up, okay? And these are based on real cases, but I've changed some of the details to preserve the confidentiality and anonymity of the patients. The first is a case I was consulted on many, many years ago in a surgical ward. And it was a situation of an elderly patient who had suffered a stroke and was not able to speak for herself. And as a result of her stroke, was not able to eat and drink on her own. And so, not knowing how things were going to turn out, in the immediacy of the situation, the surgeon put in what we call a Dobhoff feeding tube. It's a tiny tube that goes through the nose into the stomach so that we can feed the patient. When the patient was starting to revive and get more conscious, she was very distressed and was starting to pull the tube out. The family came and said, no, 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 doctor, stop this. You know, she would not have wanted this. She just, if she had a bad stroke, she would have wanted to be allowed to die peacefully with dignity and be left alone. And the doctor said, well, would you have any proof of that? Did she sign any forms? How do I know that? She's new to me. I don't know her. How do I know that's true? This is a life and death situation. I really need to be sure. And I know I still have hopes for her recovery. So I want to put in that feeding tube and keep it in there. And the family was trying desperately to convince him, saying, oh, look, we know her really well. You got to stop this. She would not have wanted this. And the patient herself kept trying to pull a tube out. And the surgeon, feeling very strongly it was his duty to preserve life, actually ignored everybody and sutured that tube into place so that she couldn't pull it out. That's bad. We don't do that anymore. And the reason I'm bringing up the case is that's what sometimes used to happen in the past. The chances, honestly, of that happening today in the hospital I work are virtually almost zero. We don't do that anymore. But here are two other cases where you should be concerned. Okay. The second case, again, based on a real situation I've encountered many times, we had a patient in the ICU who was, again, not likely to ever leave the ICU. He was not going to survive this hospitalization. He was very gravely ill, multiple complications. And he had, all those tubes and everything we do to you when you're in our intensive care unit. Well, this poor gentleman had had enough and said, that's enough. Can you please stop everything? This is torture for me. I don't want this anymore. And the nurses felt so badly for him. He actually would cry and grab their hands and say, stop this, pull these tubes out. I don't want this. And they said, well, that's okay with us, except that your family keeps calling and are very angry with us. They think we're trying to kill you. They want us to continue doing everything. So, they're threatening lawsuits if we take these things out. They're threatening to go to court. They're really, really upset with us. So what did we do? We said, well, why don't we get everybody together at the bedside and we can have this out in the open. The family can be there, the patient can be there, we'll be there, and we'll settle this, because we don't have a problem stopping things if that's what you all agree to. What we do have a problem with is stopping everything when the family's saying we're going to sue you and take you to court because that's not what their father wants. So sure enough, the family shows up and saying, Dad, tell the doctors that you want everything done. They're telling us that you want to die. We know that's not true. Now you can imagine this poor gentleman is at the end of life. He's in the ICU. He's exhausted. He's tired. The last thing he wants is to get into a fight with his own family. So he meekly shakes his head saying, oh, okay. And the family turns to us and say, you see, he wants everything done. You're just trying to get rid of him. What's my point there? My point there is it's not us that's often trying to keep you alive against your wishes. It's often family and friends who can't come to terms with your impending death, who are threatening us with lawsuits and angry and screaming and yelling, and we're caught in between. I'll give you a last example, and then we'll continue with the presentation. I was also working, in addition to the hospital, I used to work quite many decades, well, not many, 2 decades, in the CLSCs, home, and we had a really excellent home care team in palliative care. And there was a patient who was, again, end of life, a cancer patient who was nearing the end, and we had excellent palliative care nurses go in there to help out, both the patient and her family. And they all understood that, this patient probably had days to weeks to live, and it was coming to an end. And the nurse was trying to prepare them how to handle the inevitable death. It'll be calm. It'll be fine. I'll be there. We have all the medications in place. Everything will be okay. Call me when you think things are happening. I'll rush over. What happens? Everybody's saying, oh, that's fine. That's fine. Thank you. Thank you. Thank you. When the time came, when the patient looked like she was very short of breath and coming to the end, you know, they instead of calling the nurse, what did the family do? They panicked. Totally understandable. I'm not blaming them. This is a normal human reaction. But they panicked and they called 911. They said, come, quick, get her to the hospital. She's not breathing well. Ambulance comes, takes the patient. She ends up in our emergency room. Emergency room doesn't know this patient from anybody. We don't know about what her wishes are. We have to do what we have to do. So what's the take-home message from both those cases? If you want your wishes respected, of course, we'll go over which forms you can fill, but it's not the forms that are going to guarantee that you get what you want. What's important is that you let the people closest to you, typically your family and friends, know what you want and know that they agree with you, that they will not be an obstacle. In 90% of the consults I get now, it's not the doctors that are the obstacles, don't want to respect your wishes. It's the family who can't let go. So keep that in mind. Too many of the people I know fill out the right forms, and then they keep those forms a secret. They don't share them. They don't tell their family and friends that they filled out these forms. Then the family says, we didn't know about that. No, that can't possibly be true. So talk to your families, talk to your friends, and that's your best chance of having your wishes respected. Now let me move on with the actual forms. So the promise is, here's the different kinds of medical directives you can fill out. There is a certain bureaucracy, and it is important to have these forms for some people. It can be very helpful. I broke them down into two categories, okay? The first one is the kind you probably have heard about. There's the mandate for healthcare. And there's these, what they call DMA, Directives Médicales Anticipées, advanced medical directives. So there's different ways there's not just one way of doing this. The second category of forms is the kind of forms you get filled out once you're in the hospital. You may not be dying yet. You come in because you're very ill. And typically we'll go through these, what we call goals of care, levels of intervention forms. So we have a sense of how aggressive or non-aggressive do you want us to be. They're both kinds of advanced directives, but they serve a different context. So I'll cover both. Okay, let's go through the first one, a mandate. What does a mandate mean? So this has been in place for quite a long time. In Quebec, we had decided quite a while back that the idea of a piece of paper with your wishes written on it like a living will was not that helpful. And the reason it's said is not because we don't want to know what your wishes are, it's because those forms tend to be very non-specific. And we used to go to our notaries and there'd be a little phrase in there saying, I don't want any, if in the event I'm really, really ill, I don't want any heroic measures taken, etc., etc. And we would say, well, what's heroic measure? What's heroic for Patrick is not what's heroic for me. It's not what's heroic for you. What do you actually want? Do you want CPR or not? Do you want dialysis or not? What did you want? Well, most reasonable families don't sit around the dinner table saying, oh, today we'll talk about dialysis in the event I should have a bad stroke. That's not your typical conversation, right? So people didn't, in the end, know what you would have really wanted. So instead of a living will, Quebec said, let's really give a lot of strength to the mandate. And what that means is, instead of telling you what I would want done, I can't imagine all the things that might happen. I will name who should speak for me when I can't speak for myself anymore. Okay, so typically it's say, I trust this person to represent my preferences, and their job will be for you, the doctors, to listen to them because I can't speak at that point. And you should listen to them as if you were talking to me. That's how your rights continue to be respected. Fine. Well, let's look at the strength of that. Again, I'm just showing you these slides just to reinforce how powerful patients' rights are, even if you don't know that. So in the Civil Code of Quebec, I'm just repeating, no one may be made to undergo care of any kind, even life-sustaining care, even, ICU care. Nobody can be made to undergo that care, whether for any reason, except with their consent. No consent, we can't do it. And except as otherwise provided by law, the consent is subject to no other formal requirement and may be withdrawn at any time, even verbally. So in other words, you might initially consent to going to the ICU. And if you find that, look, this is not what I want, my wishes are different, you don't have to fill out any forms. You just say verbally, as long as you're competent and informed and know what you're asking for, that's enough, I don't want this anymore. And that's enshrined in law. You don't need forms. Now, if you reach the point where you become incompetent, which often happens when you're towards the end of a very severe illness and you're either too ill to speak or you're heavily medicated, can't speak. If the person concerned is incapable of giving or refusing his consent and has not drawn up an advance directive, a person authorized by law or by a protection mandate may do so in his place. Okay, so let's be very concrete and specific. I'm the patient. Eugene's the patient. I reached a point where I'm no longer able to speak for myself. I did not draw up an advance directive. Somebody can speak for me. If somebody who's legally able to represent me. Well, who can that be? Well, that can be a tutor, a curator, a mandatory, typically a mandatory, right? And that person has certain rights. Now, let's look at this very carefully. A person who gives his consent or refuses care for another person, the person who represents me, is legally bound to act in the sole interest of that person. And as far as possible, with any wishes the latter may have represented. So be very careful here. I'll give you a very specific example where this did not work. Somebody named as their mandatory a person who was very close to them but had a very different philosophical view on life and didn't know that they were named as the mandatory and said, whoa, I can't say stop or pull the plug. That's something I can't do. Well, they picked the wrong mandatory. So be very careful. The person you pick as a mandatory should be somebody who not only knows what your wishes are, but feels comfortable expressing that. And that's not a given. I have close friends, for example, a couple that have been together for 40 years. I'm having dinner with them and the wife says, if I'm ever in a vegetative state or really in a bad coma, I wouldn't want them to do anything. I'd want them to pull the plug. She looks at her husband of 40 years and they love each other intensely. And he says, I could never do that. Well, she better not pick him as the mandatory, right? Because he's not going to follow through. So we often know what we want, but we don't then strategically pick the right people to be there to help us have those wishes respected. Very important. And it's not because the people don't like us or don't respect us, it's because emotionally or psychologically or philosophically, they simply can't go there. And you might be surprised, but the number of cases I've been involved with, good, loving, caring families, where the partner or the daughter or the son simply can't do that, you'd be amazed. The daughter says, oh, I can't deal with the fact that dad wants to stop. No, I can't let him go yet. Well, don't pick her to represent your wishes. She's not going to be able to. She's not a bad person. It's just too hard for her. So be careful to pick the person who can represent you, who's willing to represent you, do it the right way. Now, that person who represents you has to ensure that the care that they're agreeing to is beneficial to you. They can't just agree to anything. It has to make sense. Next slide, and I'm going to reduce this and kind of make it more understandable. It basically says that, let's say you did not name anybody as a mandatory. People say, oh my gosh, well, I don't know who to name. Who should I name? I don't have a mandatory. Do I have to go to court? Do I have to fill out a form? How do I do this? I'll be very honest and straightforward with you. I do not have a mandatory. Why not? I happen to be one of those lucky ones. I don't need one because the law says that without a mandatory, consent is provided by other people, including the married civil union or de facto spouse. Or if there is no spouse or the spouse is prevented or unwilling to do act in that role, a close relative or another person who shows a strong interest. Okay, so in other words, you don't even need to have the form. If you have a spouse or a close person who knows you well, we have to listen to them if they say, I'm representing Eugene. I know what he wants. I'm his wife. I've been with him for 45 painful years. Pull the plug. You know, she'll know what to say because I trust her to know me. I didn't even have to fill out the forms. So I'm making this point just for you to understand. Forms are helpful, but at the end of the day, we as physicians will talk to whoever is there who can represent you. Just make sure that those people are there and know your wishes and will advocate for them. And too often, the patients, in anticipation, fill out a whole bunch of forms, but don't talk to their families and loved ones and don't say, please, 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 don't be an obstacle to having my wishes respected. It was just a few weeks ago, actually, Patrick and I both sit on the Commission for End-of-Life Care, and we were aware of a case, I think was in the media, not in our province, in another province, where somebody had filled out a request for medical aid in dying, legally done, everything was fine. And the wife challenged us and took everybody to court saying, oh, you can't do this. Why? Because she was not ready to let go. Well, the law in Quebec is clear. It's not about the wife or the son or the husband. It's about you, the patient. And your family cannot get in the way of your wishes, but you have to let them know so that they don't become an obstacle. You have to get them on board before. That's where the hard work is to be done, not filling forms. Okay, let's move on to the other kind of medical. Not that I'm finished with the mandates and the family representatives. Let's go actually with the advanced medical directives. So finally in Quebec, we have these were enshrined in law about 4 or 5 years ago under Bill 2. And they give you, again, very strong powers in a form. This was fairly new because up to then, things were kind of perhaps not as legally strong as patients would have liked and should have had. So first of all, you can either consent to or refuse care, but it's only about care that is offered, that is reasonable to offer to you. Once you've filled out these forms, they are put in a registry. Okay, they're registered at the government, at that AMQ registry. And they are legally binding. They take precedence over any other kinds of forms. And when we look at those forms, and as long as they were properly done, it was a fully informed, non-coerced, non-manipulated consent, the doctors are obliged legally to respect it. Well, that's very, very good, but it's not perfect. And here's why it's not perfect, but it's great progress. Here's where there's a problem. That particular advanced directive form that exists through the government is limited to these 3 scenarios. It only applies in situations where you have a severe, incurable disease at the end of life, or you have a severe and irreversible cognitive deficit, like an irreversible bad coma, or you're in a neurovegetative state, or you have some other severe and non-reversible cognitive deficit, like severe dementia or Alzheimer's. Now, in fairness, that covers a lot. It doesn't cover everything. So the advanced directive only applies if you're suffering from one of these 3 kinds of conditions, okay? And for those 3 conditions, you can say you can consent to or refuse these 5 things. CPR, where we try to resuscitate you if your heart stops, putting you on a ventilator, giving you dialysis, giving you food and fluids artificially. So these are very powerful advanced directives. If they're properly done, for those 3 conditions and for those 5 acts, they will be legally binding. So let's just go back for a second. If you're somebody who has let's say, an end-stage cancer, a severe incurable disease, and the doctors say you have, 3 to 6 months, you could fill out one of these forms and say, I want no CPR, no ventilation, no dialysis, no. You put, that is registered in a registry. And when you show up at the hospital, theoretically, we are obliged to look up at that registry, see if you're registered there, pull out that form, and if we see that, unless we have serious doubts as to the authenticity of that, we are legally obliged to follow those directives over anything else you may have filled out before. So that's fairly new. The downside of that is that, I don't think the medical community is fully aware of that yet. And so not enough of us are perfectly aware to know to even go and check those registries. So that's what I mean. Life is complicated. The system is not perfect. So while it's important to do these forms, my take-home message to you is don't just rely on the bureaucracy of filling out a form. Nothing is as powerful as having a communication between people. They're the ones who represent you best, not the form. Form can be done. We didn't check it. It wasn't there. People can say, oh, well, you didn't do your job. But at the end of the day, it's having your wishes respected that's important. What's the best strategy to have that done? Now, you can get this form. People say, well, how do you do this? I'm not going to go too much into detail of the mechanics of it, but the form is available to you if you call that number. That's the number I was told you. I've never done this, so this is not from first-hand experience. But when I looked it up, it said, you call that number, you ask for the form, they will mail it to you. You have to fill that out yourself, and you have to have 2 witnesses or a notary prior. You have to then have it registered. And then it has to be respected by the medical team. Interestingly, you should know that in this form, you cannot ask for medical aid in dying. There's one of those things in the law that's explicitly left out that you cannot ask for in these advance directives. We won't go into the whys of that, but suffice it to say, you can possibly get medical aid in dying, but not through an advance directive, at least not now. We don't know what the laws will change. But for now, medical aid in dying cannot be done through these particular forms. Some people who are more tech savvy than I am don't have to call and get it in the mail. They can actually go to this website, and that's how you navigate down, and you can get these forms and do that. And I'll skip. Now, before I go on to the next section, please remember, here's one of the pitfalls. People say, oh, I filled out this form, I registered it, I'm safe, everything is going to be perfect. The basic laws on consent still apply, which means when you filled out these forms and you said yes or no to these different things, we assumed that you knew what you were asking for. You talk to somebody, you know what dialysis means, you know what your condition is, you've made a meaningful decision. And with no disrespect intended, the vast majority of you will know that, but we come across cases where people fill in forms that they have no idea what they've checked off, and they're contradictory. So if you're going to fill out an advance directive, please speak to somebody that you trust, that you know, to make sure that you know what it is you're actually asking for. Because let's face it, once you check, those are legally binding. Okay, so the normal legal and ethical parameters for consent still apply. You have to understand it, you have to know what you're doing, you have to be competent at the time of filling out those forms. Let me move on. I know it's a lot to cover, but these are all powerful tools that you need to be aware of and know how to use to the best of your advantage. So I'm stopping with those advanced directives. I'm now moving to the kinds of directives you get when often you are admitted either to a hospital or a long-term care facility where we fill out different kinds of forms, and they're often called goals of care or levels of intervention forms. So typically, you know, Eugene shows up to the hospital as a patient. His heart is really overacting again because his colleague Patrick is putting too much stress on him and he's in the hospital. And the doctors will come and say, you know, you're not in great shape, but we just want to make sure that should our care not make you better as well as we would like to, we need to know what to do if things deteriorate. And they go through this exercise with you typically, okay? So just remember, the goals of medicine are there are many. We're there to cure you. And if we can't cure you, sometimes we're there to make your life as long as we can, if that's what you want, to restore, improve your function, And if all those we can't do well, then we have a moral duty to also promote comfort and quality of life and to minimize the suffering as much as possible. So what the goal is for me at different hospitalization may change depending on what that particular circumstance is. So I'm going to give you some specific to the forms that are standard in Quebec. And we have 4 typically different goals that are listed in these forms. Goal A is, some people say, I want everything done with all the possible things you can do to me, because after all, I'm 39 years old, I'm trying out for the Olympics next summer, and I just want to make it. So whatever it takes, go for it. That's goal A. Prolong life with all necessary interventions, surgery, chemotherapy, whatever it takes. Some people say, well, no, I don't want that. I want to prolong life as much, but with some limitations. I don't want to have 16 surgeries on this. If you can keep me going with X, Y, and Z, but without going overboard, that's what I would want. Others quite reasonably say, no, I don't want either of those. I'm 92 years old. This is my father. My father died when he was 97. He said, Eugene, I'm 97. Enough already, stop. I don't need this. I just want to make sure my comfort is a priority. Don't give me an extra year. Whether I make it to 98 or not is less important than what I have today makes me comfortable, pain-free, and not suffering. That's my priority. And some people say, forget about prolonging life. Do whatever it takes to ensure my comfort. That's the only thing I'm worried about. So you can see that those are very different goals. And it's important for the medical team to know which of these goals you want. And it can change. When you had that filled out when you were hospitalized 3 years ago, it may be very different from the hospitalization you're going to next time. So please keep that in mind. And when you're going through those forms in the hospital, they should be doing this and making clear what it is you want as a goal of care. I won't go into this next slide because it gets very minutia. Then they start, once they know what your goal of care is, then we can start negotiating, not negotiating, but discussing with you, well, does that mean CPR? Does that mean dialysis? Does that mean surgery? And we get all those details ironed out. But those are codified in these forms, and we try as much as possible to have those respected. Okay? So we've covered, let's take a deep breath for a second and pause, because that's a lot of information. Let me sum up where we are so far. So what I'm saying is, first, let's just remember where the main take-home messages so far is patients have very powerful ethical and legal rights. Doctors can no longer, like they did 30 years ago, do whatever they want to just because they feel like it. We are legally and ethically obliged to respect, to the extent possible and reasonable, your wishes. We cannot even provide life-saving care without your consent to it. And if you are not in a position to consent because you're too ill or can't speak, then you don't lose those rights. Somebody can represent you. Then the challenge for you is make sure you've picked the person who will represent what you want and won't be stuck with their own issues that might get in the way. Okay? So the forms are important. Fill them out if that brings you comfort. But my suggestion is it's important to communicate so people are aware. Your family, your friends, your closest people aren't caught off guard at that moment and say, oh my God, no, that can't be right. I think that's wrong. And they start to get in the way, and that can cause real problems. So are there pitfalls? Yes, there are always pitfalls. The world is not perfect. What are they? Well, there are legal pitfalls. There's a feasibility. There's cost factors. I mentioned some of them already. For example, we have this registry, but it's relatively new. And in the heat of the moment, people might not go straight to the registry and find your registered advance directive and check it and verify that. You will ultimately get what you want, but there's no guarantee that will happen in that instant. I've heard people complain, said, I filled out all these forms, I talked to everybody, and then I showed up in the emergency room because they took me by ambulance there, and they still ended up doing things to me. How can that be? Well, think about it. Look at the other side of the coin, right? when you show up by an ambulance and emerge, and those of you who've been in the emergency room know it can be like a war zone. We don't know you, we don't know your situation. We have a sick person coming in whose heart stopped or something's going on. And the first instinct is not to say, oh, let's take a deep breath and go look for forms. Our first instinct is to do what we have to do medically. That's just normal. So it may be that your wishes it may take us a few hours to find those wishes and implement it, and we can always do that. But people should not have the expectation that once I fill out a form, it's a guarantee they will never touch me. And the biggest risks to your wishes not being respected is not just because your forms weren't filled out, is because somebody is going to rush in and say, oh, no, they didn't know what they were asking, don't do that. And then we have to try to deal with that. So what's the solution? Well, I'm not anti-form. By all means, fill out whatever forms you want. When you fill them out, get some advice and counseling from people who know what they're there for. Ideally, your own physician. You would stop and talk to your physician about these, so that make sure that your decisions make sense and represent what you want. Fill those forms out, have them registered, submit them. But more importantly, in my opinion, based on my experience, don't keep those wishes a secret. Family dynamics can be complicated. And some people say, well, I didn't want to bring it up at the family dinner. I didn't want them to know. A, I didn't want to cause trouble. B, I didn't want to upset them. And C, I know that they won't agree with me and they're going to give me a hard time. Well, guess what? If you don't talk about it, they're going to give us a hard time from respecting your wishes. So the obstacle these days, the world has changed. There are always those, the world's not perfect. There will still be those doctors who think they have to do everything despite your wishes, but they are fewer and fewer and fewer. Where we might have trouble is where we're ready to respect your wishes, but your family comes in, guns blazing, not literally, but saying, no, mom couldn't possibly have wanted that. We'll sue you if you do that. And that's almost a daily occurrence. So keeping it a secret from your loved ones is not strategically a good thing for you to do. If you want people not to get in the way, you have that discussion, the hard discussions now, and you say, son or daughter or uncle or niece or whoever it is, these are my wishes. This is what I want done. I've written those down in forms. I've submitted them. Please, please, please respect those when the time comes. Do not interfere. Do not get in my way. And most families are good, loving, caring families. It just that's notwithstanding that, it's really sometimes for them very hard to be in your shoes when you're that ill. And they will say, no, that can't be. And they try to stop us. So please share your wishes and communicate them. Forms are step A, but they're not a guarantee. Fill out the forms and then have those conversations and make sure that your entourage, your closest people who are going to be there to represent you, know and respect those and will advocate for you. And those are the best. I would say one last thing there is another strong way to enshrine and protect those is if you're lucky enough to have a family physician or a primary care physician. Let's say you're a cancer patient and you have a cancer doctor who's been following you for 10 years. Have those discussions with your doctor, and your doctor will chart those in the medical chart. And that chart, it's worth its weight in gold, both ethically and legally. If the family shows up, let's say again, it's me, I'm the patient, and I say when I have a major illness and after 3 rounds of chemotherapy, I don't want any more, I fill out the forms, but my family comes and screams and yells and say, oh, no, keep doing everything. The fact that I had that conversation with my doctor and my doctor charted that in his chart or her chart is a huge legal plus. All the physician has to then go in front of a judge and say, Judge, I've known this patient for 5 years, had multiple conversations in depth on this topic, and here's the documentation. On Saturday, November 5th, I had this conversation and it's clear to me, patient was competent, knew what she was asking for. I agree with it. We've signed it. It's here in my medical chart. That it's worth its weight is gold as much as any form will. So talk to your doctors, talk to your family and friends, make sure everybody's on the same page. And from my perspective, based on my experience, that's at least as important, if not more important, than the actual forms. I think I've come to the end. So I hope I haven't thrown too much at you, and the rest I hope I can clarify. I'll try my best with any questions you might have. So thank you for your attention. I hope it wasn't too much all at once.
Thanks, Eugene. We have a few questions from the chat room, so I'll try to cover them. The first one is somebody discussed with his children and had appointed his son as a mandatory, and he said that if he has permanent loss of a condition, that he only wants comfort care. He found that advanced medical directives were too complicated, too contrary to fill, and he want to make sure that it was a good decision. So do you imply that it's better to appoint a mandatory, or it's not necessary because he's the next of kin?
So if I understand the question, I'm sorry, I didn't hear that last part.
You imply that that it's not necessary to have a mandatory because the son is kind of the person that's closest to him.
Okay, so every situation is unique. So if the only person in your family entourage left is your son, then you don't have to name him as a mandatory because he's the only one left. Why you might name him a mandatory is if you have a son and 2 daughters and an aunt and an uncle, and they all want in on the decision. Well, then you better tell us which one it is. We've had some problems where we go and we say, well, we'd like to listen to the representatives, but there's 5 of them and they each have a different opinion. How do we know which one we're supposed to listen to? So if you only have one close family member left alive, then you don't need that form because they're going to say, I'm the closest family member, there is nobody else. Then that's okay. We'll listen to them. But if you want us to listen to your son, but there are also 3 others in the picture who are going to come and give different views, then if you want us to listen to your son, in the face of those 3 others, have him be officially the mandatory. Does that answer the question? Yeah.
Yes, I think so. And one other recommendation is maybe to appoint also somebody else, a substitute person, a substitute that's a mandatory, because that son may not be available in 5-10 years ago from now when the situation will occur.
Right. Excellent question. So it's like, I would suggest to people, think of it like any other will you make, right? You made a will 30 years ago where you left everything to your close friend, Harry. And then 10 years later, he's no longer your closest friend. In fact, you had a falling out and you hate him. And now your closest friend is Joe. But you didn't ever bother to go and change your will. Well, how we're supposed to know that? In other words, if you have these, it's your responsibility to keep them up to date.
Good point.
And typically, most people do put a second person down because, again, world's not perfect. I could name somebody as my mandatory. I happen to have a heart attack at a time when that person's on vacation in the Soviet Union, in Russia. Well, pretty hard to get in touch with those guys and figure out what's going on. It's always good to have a backup, but keep those current. And believe it or not, the number of times I have not only 1, but 2 substitute decision makers listed, and neither of those 2 people knew that they were substitute decision makers. We call them up and say, Frank is sick in the hospital. He listed you as a mandatory. Can you please come in? They say, what? What are you talking about? I didn't know. He never talked to me about that. So again, don't dump this as a surprise on people. You got to coach them. You got to talk to them. You got to let them know. It's not a secret, okay? Which is different with the will. Sometimes you don't want to let, in the financial will, people know that you're leaving money to them. But for this is different. Don't put somebody as a mandatory and not tell them.
Okay. There's another question or a comment. Somebody was appointed as a mandatory, a wife for her husband, and the doctor always presses her to make all decisions for her husband without giving too much medical information to guide her. How would you help that wife to get a bit more information?
Okay, so I'm assuming that the patient
is inapt.
Is inapt and can't speak for themselves.
Correct.
So the mandatory, let's say the spouse, is being pressured by the doctor to make a decision, but is not getting the information he or she needs to make that decision well, right?
Yeah, she doesn't have access to the chart, and she has limited information, and the medical teams are not giving her all the information to make a good decision.
Okay, so that's, I have to reluctantly admit that does happen. It's too bad that happens, and it's not because of ill will, but sometimes I'm not making excuses for them. You know, look at what's happening these days.
Very interesting. It's very important. I've learned a lot.
You know, is that so? Jerry.
Sorry, could you mute your?
Yeah.
What are they talking about?
They're talking about what you have to do to prepare properly for.
Sorry, I guess you could continue. Eugene?
Yeah, can you hear me?
Yes.
Okay, let me repeat the answer. I'm saying it's true that sometimes the teams seem so busy they don't take the time to give you the information you need. We should, but sometimes we don't. This is where you have to be quite strong and know that it is your legal and ethical right to have that information. You just keep asking for that. Now, if you do hit a roadblock, the rest I'm giving you just personal recommendations on the strategies. There are other people to talk to, okay? You can go to the head nurse and say, listen, I'm trying to make a decision here, but the doctor isn't around. I'm not getting the information I need. Please help me. The nurses can be very strong allies to help mobilize that team. If you're feeling overwhelmed or you can't or the doctor's not around, go to the nursing station. I say, I need to speak to the head nurse. This is very important. I'm not getting the information I need. Let's say it's worse than that. Nobody's cooperating with you for whatever reason. You can always go then to what each hospital has, what they call a hospital ombudsperson. It's very important to know there's always a system in place to protect your rights. You ask to get in contact with the ombudsperson. You say, I'm not against the doctors. I just don't get to spend the time with them. I need to get information. Can you help me? And they are there specifically to help patients' rights be protected in that way. That ombudsperson will then contact the doctor and say, excuse me, the substitute needs information. He or she feels frustrated. She's not getting information she needs. It's important for you to know that you have a legal obligation to provide her with that information.
Thanks. Another question from the audience: if the forms have been completed, like she's referring to the mandate, and the mandatory has the advanced directive, but they're not registered, will they still be honored? Our recommendation is probably to have them registered so it's accessible for all doctors in Quebec. You know, it's always better to register them.
Exactly. The main point about the registry, then doesn't matter where you are, it's in the central registry, right? Yes. But for argument's sake, you didn't register it. Look, at the end of the day, you need to know that, generally speaking, the medical teams are there to, in fact, have your wishes respected. And look, in my day, when we didn't have these advanced directives, we just looked for any reasonable evidence to know what you wanted. Notarized, not notarized, registered, not registered. We looked at whatever we had. We'd speak to the family. We looked at whatever forms were filled out. And if we felt confident that this represented you, that was enough for us. We're not going to ignore them because it doesn't have some stamp from a bureaucrat somewhere. So it's not the form itself that's important, it's the information and us having confidence in that information and who is giving that information that's important.
Thank you. Another question about advanced directives in case of dementia-related condition. If I write my advanced directive before the onset of dementia and my dementia kind of progresses, and that there's a clash between what I'm able to express when I have dementia and what I've written in my advanced directive. How would that work?
Oh my gosh, you really like giving me a hard time, don't you?
It's the audience. It's the audience. I'm just a messenger.
That's gonna cost you extra. To be honest, that's a very, very, very hard one for me to answer well. I'll tell you why. And it's controversial. So what I will give you as an answer is not what some of my colleagues were, and I'm not the authority on this, okay? But from an ethical perspective, it's a real conundrum. Why? Well, think of this. Put yourself in the shoes of the doctor, okay? And I've had those cases where the patient says, while before they're demented, right? Oh, when I'm demented, I don't want this done, I don't want that, don't give me the flu shot, don't take me to a hospital, just let me die, right? And then, you know, there's dementia, there's dementia, there's dementia. If you have 100 people with dementia, you have 100 different kinds of presentation. They're not one cookie cutter size fits all. So there's some people who are in distress and are anxious in their dementia, and there's a few who are actually very calm and pleasant and seemingly content, right? They sit there pleasantly and they're not in any anguish. And you say to them, you go to them and say, you know, Jenny, you have a high fever and your heart is racing. You know, this is something a simple drug will fix. We can give you something for the atrial fibrillation. You'll feel better. What do you think? And Jenny looks back to you and smiles and say, that's nice. Okay. What am I supposed to do? Let her die within a couple of days because she didn't get a single medication for Z? I'm not talking about surgery or major interventions, right? I'm talking about giving her a pill. She's happy, she's content. When she filled out the advanced directive, when she was before dementia, did she really think to that level of detail? So it's pretty hard sometimes for us to withhold a simple interaction like an antibiotic pill for something that we can easily reverse when the person says, yeah, okay, I'll take that. We're not forcing it on her. And so some doctors will say, it's really hard for me to not give a simple intervention for a person who's saying, yes, okay, I'll take it, and do not seem to be in any distress. I don't have the right answer to you. Some people feel very strongly, I don't care what I say in the future. You listen to what I said when I was, before I became demented. But I'll give you an even more powerful example. I had a colleague of mine actually who was a doctor who filled out an advanced directive saying, don't ever intubate me if I have a bad cardiac condition. He was a smoker, had a cardiac condition. Say, I do never want to be in those ICUs. I know what it's like. I've been there. I do not want to be in the ICU. Don't ever intubate me or ventilate me. Ended up in our ICU, of course. And we were monitoring him and he was getting really short of breath. Now he's a little confused because he's already not getting enough oxygen to his brain. We go over to see what we should do. And the doctor said, you know, people change their minds. So I just asked that you once again, I know in your form you filled out, you said you didn't want this. I know you're a little confused now, but you're short of breath. Should we intubate you and ventilate you, or should we give you enough medication to cover you for comfort so you're not aware of it? And intubate me. Well, it seems to go completely against what he wrote in his form. And he's a bit confused. What am I supposed to do? Say, sorry, too bad, you filled out a form. I'm listening to the form. I'm going to let you die. It can, you know, life is not black and white in boxes. And we've faced these really challenging situations where there's no obvious right answer. So I know it sounds like a cop-out. What we would try to do is then talk to, not make that decision ourselves, but we would reach out again to the mandatory and say, oh, what do you think we should do? You knew the person way longer and better than we did. We're only the doctors. You've known them for all your life. In this situation, should we withhold that simple pill and let her die? Or do you think she would have been okay with that? That's the best we can do. There's no perfect answer to those.
Okay, there's a few comments from people just to assure them that this session has been recorded and will be available on the McGill Palliative Council website afterwards, so you don't have to take extensive notes, but it's going to be available in the near future. Next question is about the RAMQ form. I guess it's the advanced directive. I just posted the phone number of the RAMQ. Haven't done it myself. It's easier to do it by phone. You take your RAMQ card, you call the RAMQ. and they'll ask you to identify yourself, and you give your RAMQ card number, and they mail the form to your home, and it's easier to do it that way. Of course, if you have your Click Secure Access code that you get from your income tax, you could also download it on the RAMQ website. So it's another way to do it. Another question from the audience is there a mandatory specialist by profession? Is there a mandatory specialist by profession? She asks, or he asks, she asked her notary, and that notary didn't seem to know the details about a mandate. Surprising.
Yeah, so that's a bit surprising. So if you're asking me, are there such people who make a living by being mandataries for other people? Then,
yes.
Then I'm not aware of that, no. In other words, you're saying, is there an all professionnel des mandataires, where I can call them up and saying, you're going to represent me when I'm sick? I've never heard of that. That doesn't mean they don't exist, but I'm not aware of that. Most people, I think, reasonably prefer to pick a mandatory who knows them well. And I'll tell you why. Because you cannot possibly anticipate all the variables of what might happen. To sit down with a mandatory and go over every possible scenario, you'd spend hundreds of hours with them. Oh, if I have a stroke, if I have a heart attack, if I have this kind of thing, if I have that kind of thing. I mean, the sky's the limit of the number of kinds of scenarios you might confront, right? Mm-hmm. Now, even me with 30 years of practice, I don't go home every night and say, okay, it's Thursday, let's talk about dialysis. This is what I would want in case of a stroke. You know, I don't cover all those with my wife. That's not the point. What I want my mandatory is to pick the person who knows me, whatever the situation. Say, I know Eugene so well, I'm pretty sure I know what he would ask for in this situation, even though we never spoke about it specifically. So don't pick a stranger. That's my advice, personally. So that's why I don't think there's professional mandataries. You know, you pick somebody who really knows to represent who you are as a human being. That's the best choice.
If there's two siblings with different opinions for one parent, what the doctor do?
So this is why I think in that situation it's really important to then, in fact, have a notarized mandatory. Why? I've lived through many of those scenarios. You have two children, very different points of view, and they're trying to represent you. Well, as a doctor, it's hard enough for me to be a good doctor to take care of you medically. At the same time, I'm not there to play family court judge. Oh, I like Frank, so I think this son is better than that son. That's not my job. I can't possibly sort that out. I don't know who's telling the truth or who's smarter, who's better, who represents you better. So if you want the son who represents your wishes to be the one who actually we listen to, give him the mandate. That's the way around that.
Next question. My two children disagree on my end-of-life care. One accepts the idea of a maid, medical aid in dying, and the other one doesn't. Can I appoint a mandatory outside of the family who has the final authority?
So again, you can appoint somebody outside your family to be a mandatory for sure. It doesn't have to be your family member. But I'm just saying, but pick somebody who knows you. So let's say if I have this scenario, which is not unusual, two family members who disagree. Well, actually, sorry, let's back up. Under the current law, it may change soon, but currently, to get medical aid in dying, you have to be competent at the time of receiving it. So the mandate question becomes moot, right? You have to be competent not only at the time of asking for it, but also at the time of receiving it. So if you're competent at the time of receiving to it, I don't care what your other guys are saying. I talk to you. I don't talk to anybody else. Your family cannot interfere with what you want as long as you're competent, right? And once you're incompetent, it doesn't matter who your mandatory are, you will not be able to get medical aid in dying. Medical aid in dying is only available to patients who are competent at the time of receiving it. Now, there's some talk that that law might change, but I don't have a crystal ball.
Good point. And you could also appoint a mandatory for finance and a mandatory for personal care.
Exactly.
So there's different combinations you could discuss with your notary to make
Yes.
sure you have the right person to make the right decision on your behalf.
But Patrick, I would like to come back for a second and stress that point that the mandatory doesn't have to be a family member. So if I only have 2 family members and they're fighting and they disagree, there's nothing stopping me from appointing my closest friend who's been my best friend for 40 years and really knows me well. If I make him the official mandatory, that person jumps to the top of the list ahead of my family.
Another question or comment, important to have mandatories and executors in our province. It's very complicated if you live in other provinces, because the laws could be a bit different. Power attorney could be different from a province to a different province. So that's a good point.
Yes. So, but that actually strengthens one of my main arguments where, you know, let's say you're an Ontario resident and let's say they have different regulatory frameworks and different forms and different this and different that, right? But you happen to be sick and you're hospitalized in Quebec. What would happen? So at the end of the day, that's what I'm saying. That's why it's so important to not rely as much on the form as having the people who we can trust and listen to who represent you. We will do what you want as long as we have the confidence in the people who are there to speak on your behalf. So we don't say, oh, no form from Quebec, tough bananas, we're going to do whatever we want. No, c'est pas comme ça. If we don't have Quebec forms, we're going to say, oh, you're the son, you're the daughter, you had the mandatory or the equivalent in that province. Tell us about this patient. What would the patient have wanted? And that's what we'll go with.
Perfect. Next question, there's a myth about everybody wants to die at home. Should would like to receive the final care in their place where they feel more comfortable, supported, and not alone.
Right.
Where pain can be more controlled. Any thoughts on dying at home and maybe sensitizing your loved ones about your wishes of where you want to have the care?
Well, again, that's a tough question, and I'm happy to answer it. But just to make the point, I'm hardly an expert in that. Every family is different, and you know, I've seen all kinds of scenarios. It's true. I think it's true that a lot of people ideally would prefer to die in the comfort of their own homes, if possible. And that's why I think Quebec has made an effort to increase home care and home care palliative care and all that kind of stuff. We need more, for sure, but that's the direction we want to go in. What I also hear, and this is not to contradict what I just say, is having said that, people don't often appreciate just how complicated that care might sometimes get and how burdensome that can get on their close family members. So, you know, if God forbid my wife gets sick, no problem. I'm a physician. I know how to take care of her at home, and I'll get my good support from my friends at my CLSC. But if you have somebody, let's say with a high school education, who feels overwhelmed and she's raising 3 other kids and her husband's dying and he's expecting her to take care of her at home in the last 2 weeks of his life, that might be so stressful and difficult for everybody that it may not necessarily be the best option. And then people start realizing, say, oh, I would have liked to have died at home, but I'm realizing the stress that places on my whole family and their inability to take care of me well. They have to rethink that. So there's not one simple slam dunk answer. I think good palliative care at home can do a lot, and increasing, I think that probably is the way to go, but it's not for everybody.
I think the same question was asked for prior in terms of specialists to help you fill and make your mandate. Of course, in Quebec, it's the notaries that are kind of the specialists for mandates. If the notary that you have is not specialized in that field, I strongly recommend you that you call the Chamber of Notaries and ask for a notary that is specialized in that area, so they could help you, guide you to fill it. Of course, in Quebec, you can definitely write up your own mandate, and there's a way to do it. You could always go on the Public Creator website to be able to download some forms and get you a lot of information from that website. If not, there's definitely the notaries that are equipped to help you with filling your own mandate with your given situation. So I hope that helps to answer your question. For the mandatory, is there a hierarchy in Quebec, like in Ontario, about who represent where there's not no one specified.
Right. So yes, I think there was a slide. I don't know if I can bring it back up. Give me 2 seconds. There is in fact a sequence. Let me see if I can get that. Give me 2 seconds here.
While you wait, while you look for it, I maybe answer another question. Is the mandate the same as a power of attorney? A mandate encompasses the personal care and the finance, as opposed to a power of attorney. It's mostly for finance. So they're a bit different in Quebec. So a mandate is really when you're, it comes in effect when you become inapt. And there's a psychosocial evaluation done, there's a medical assessment that's done also. And those documents are brought in front of a judge who will promulgate, who will authorize the mandatory to act on your behalf. As opposed to power of attorney, a power of attorney can be given when you're still apt to look at your finance, or it could be a notarized power of attorney, which is a bit more complicated, which you can deal with several banks to look at your finance. So there are different vehicles to represent you.
So here's the slide, which hopefully answers that question, and I will not read that because it's a bit dense. But what this slide is basically saying is when you reach the point that you cannot speak for yourself, you don't lose your rights, here's the hierarchy who speaks for you. You either went and named somebody specifically legally, like an official mandatory, could have been your best friend, or in some cases as a tutor or a curator. If you did not do that, you didn't go to a notary and name your best friend Jack to be the mandatory, okay? You didn't do that. Then, if they're not so represented, consent is given by, first, his or her married civil union or de facto spouse. Not the children, spouse. Or, if the person has no spouse or his or her spouse is prevented from giving consent, it is given by a close relative or a person who shows a special interest. So typically, in practice, my experience is we would typically first say, has he filled out any mandate forms and named somebody that goes to the top of the list, his best friend Joe? If he hasn't, then we typically go to the spouse. And if there's no spouse available or willing, then we go to the next closest person. That's helpful, but not perfect, right? Because if there is no spouse and the next closest person, well, there's 5 of them and they disagree, you're in trouble. So the onus, the responsibility, if you want your wishes respected, is to think about this ahead of time and say, it's not just I fill out the form, but I can anticipate this or that kind of conflict. If there's going to be conflict among my survivors, then I will jump and push them to the one I want, I'll push to the top of the heap by officially notarizing him as my mandatory.
And the last question is, I was appointed as a mandatory. Am I forced to be that mandatory for that person?
My personal opinion is no. First, you can't force somebody to be a mandatory. And secondly, then it's a bad choice. You know, for me to say, I'm picking my friend Patrick to be my mandatory, and Patrick says, geez, that's the last person in the world I want to be mandatory for is Eugene, then we probably aren't on the same wavelength, and that was not the right choice for me. I should pick the person who would be willing to be my mandatory, okay? So make sure you communicate those clearly. You can't force somebody to be mandatory, and even if you could, they probably wouldn't be doing the best job if they're being forced to.
Thank you. So I guess if we take back lessons that we learned for tonight is choose your advocate or your mandatory wisely, communicate your wishes to him or her. You could appoint several mandatories to look after different elements of your mandate. Of course, it's always good to educate yourself about end-of-life options in Quebec and or other provinces that you live to grasp all the options and the different obstacles you may get. For caregivers, it's also a challenge. You have definitely to know the system and know how to navigate, but you're not alone. You have like several team members that could help you to navigate. The physicians, head nurse, if there's a conflict or an issue, you don't get the information you need from the physician. Social workers could also advocate on your behalf to help you navigate the healthcare system and represent you and kind of look at all the different options for you. So the caregivers are not alone in the healthcare networks. Of course, there's the ombudsman, but the ombudsman may take time for you to answer you back, because when your loved one is hospitalized, it's really the treating team you should go back to and get the answer you need to help you to in the decision process making. So it's not easy for caregivers to represent somebody who's going through that phase of life, but you have a team that could help you. So thank you very much, Eugene, for all the time and all your words of wisdom. And what you can also keep in mind is communication, either paper form or face-to-face. But I think you did stress the impact of human-to-human communication will provide you the best care and the best end-of-life care. So again, in my name and the name of the council and all the participants,